This video is about the management of PSP, which stands for Progressive Supranuclear Palsy. We are talking about what we can do to improve the quality of life of those patients with PSP and also to improve the quality of life of the caregivers. My name is Dr. Zayas. I am a neurologist, fellowship trained in movement disorder, and a former physical therapist. The first thing I have to tell you is that the management of PSP, Progressive Supranuclear Palsy, is multidisciplinary, which means many providers working together to improve your quality of life. And not only your quality of life, also the quality of life of your caregiver. I call this team the dream team for PSP, which is composed by all of these healthcare providers that you see here in this screen. So the first one is the movement disorder neurologist, which is a neurologist with extra training, fellowship in movement disorder. So these are neurologists specialized in atypical Parkinsonism, such as PSP. Then you have the internist or the family practice physician, very important. You also have the neuropsychologist, very important in the management of these patients. They should be involved as well. Then you have the psychiatrist, specifically or especially if they have training in neurodegenerative diseases. Then you have one of the most important one, which is this one, the therapist. It's a team of PT, physical therapy, occupational therapy, and speech therapy. And especially they have experience with patients with atypical Parkinsonism, such as PSP, right? Then PMR doctors or PMR physicians. So this stands for physical medicine rehab, if available. So very important to have these doctors if they are available in your area, because they coordinate very well with the therapist. So, and they are expert in rehab. Now, the social worker is paramount. Extremely important, the social worker, especially if you want to understand all the resources available. You will need help, and your family will need help to deal with this disease. Then another provider that I consider very, very important, and it doesn't matter what type of Parkinsonism do you have, sleep medicine. Sleep medicine fellowship trained. And you have two options here. You have the option of seeing a pulmonologist with a fellowship trained in sleep medicine, or you have a neurologist fellowship trained in sleep medicine. Which one I prefer? Obviously, the neurologist. I have my bias for that, right? So neurologists tend to have more expertise in neurodegenerative disease than a lung doctor. Then you have the urologist. Why? Because the bladder is one of the organs, one of the areas, systems that will be affected with PSP. So very important, especially when things get very complex. You need the help of these type of providers. Palliative care. Palliative care is very, very important to start from the beginning. Okay? Why? Because this is a rapid progressive disease. Significantly more rapid than Parkinson's disease. This is not Parkinson's disease that I have patients diagnosed 30, 20 years ago. I have one guy 45 years ago. So this is different. So palliative care improve your quality of life. I will talk about that later. And then you have a neuro-ophthalmologist. Not every ophthalmologist is familiarized with this disease. It has to be a neuro-ophthalmologist. So you can have a neurologist fellowship trained, which is 1 year, in neuro-ophthalmologist, or you have a ophthalmologist fellowship trained in neuro-ophthalmologist. Before talking about management I believe it's very important that you understand that this disease is progressive. Actually, it is clear in the name of the disease, which is called, that's why we call it progressive supranuclear palsy, progressive. So, which means that there's no cure, and actually we don't have cure, not even for Parkinson's disease in 2025. But this help you to understand what is coming for planning and also preparation. And believe me, it will facilitate the process, not just for you, but also for your caregivers or the person who is next to you, taking care of you or helping you out. As I mentioned before, PSP is a challenging journey. And while everyone experience might be different, here I will show you what to expect over the years after PSP symptoms onset. Let's talk about mobility issues, right? Mobility issues. Usually patients start having mobility issues, and if you ask me how this is going to progress, you can see here that in approximately 3 to 4 years, patients with PSP, especially those patients with Richardson syndrome, which is the most common one and the most severe, they are actually wheelchair bound at these, after 3 or 4 years, they will be wheelchair bound, which is way different from Parkinson's disease. So you see a patient, what we call a wheelchair sign. So wheelchair during the first 5 years. Within 5 years, this is not Parkinson's disease. This is something else. Now, swallowing problems, significant swallowing problem that requires some modifications. Even 5 years, you start seeing that in PSP. Okay? Yeah, you might be choking a little bit when you have Parkinson, but I'm talking about significant issues with the swallowing. So you see that at this time, at 5 years from symptoms onset. Urinary incontinence. Remember, urinary incontinence is not a feature of Parkinson's disease. Stress incontinence, yes, but just urinary incontinence is not a feature of Parkinson's disease. You need to look for something else like MSA or PSP. So loss of bladder control typically happen after 5 years. All right, so very important that you understand that. Now, significant cognitive decline, or what we call severe dementia. Dementia, remember, means significant cognitive issues with sufficient magnitude to affect daily activity or function. So basically, that you are not independent. You depend on somebody else to do your things, your daily activity. That happened after 5 years, 6 years, affecting even memory, which is one of the domains, one of the areas of cognition, but there are many others also affect even from the beginning, decision making, multiple tasks, activity, and behavior. So that's why those patients with PSP, they behave differently. They behave different than patients with Parkinson's disease. If you ask me, and this is a very common question that people with atypical Parkinsonism and caregivers ask, life expectancy. So in average, we are talking about 5 to 8 years, which is different from Parkinson's disease by far. Okay, by far. Yes, obviously there is a variability and everything depends on what subtype of PSP do you have, right? If you have the Richardson syndrome, this is what you expect in 7 years. This is what usually patients with PSP Richardson syndrome will last. But if you have PSP Parkinsonism or PSP postural instability, it might last more than 10 years easily. So all the information I got it from here. Okay, this is not just based on my experience. This is evidence based. Now let's talk about what you care the most, which is the management. What we can do to help these patients. let's start talking about motor symptoms. So the first motor symptoms that we are going to discuss is what we call Parkinsonism. Parkinsonism, remember, means slow movement and stiffness. And there are some patients that actually they have tremors too, but it's less likely. Usually you have a lot of stiffness, especially in the trunk, in the neck, and also slow movements. Uh, if you always need to try carbidopa levodopa, always try, and you need to push the doses to higher doses because approximately 20 to 30% of the patient might respond at least initially. So you push the doses to 1000 milligrams of levodopa daily, which means approximately one tablet of the 25/250 milligrams 4 times a day. You separate every tablet approximately 4 to 5 hours, or actually 4 to 6 hours if you can. And give a trial of approximately 4 to 6 weeks, looking for improvement. And when I say improvement, you need to understand what we're talking about. So this is not going to improve your walking or your balance, your postural instability. So don't pretend that taking this medication you will improve your balance or your walking, because this is not. So we're looking here for some improvement in the stiffness and the slow movement. And it sometimes is very hard to tell for providers, and we push the doses to 1000, and then we are not sure. We tell the patient to taper down, and you can taper down the medication in a week or so. And then the family call you back saying that they are worse, so it means that something was doing, so you put them back. So that happened frequently, especially during the beginning of this disease. Okay. And very important that you guys understand that most patients with PSP fail to reach and maintain any meaningful improvement, but still it's good to try. The next one is freezing of the walking. So freezing of the walking or the gait, the first thing that you had to do, because number one, this is very common in PSP, and it can be also present. You can see that in people with Parkinson's disease as well. But in PSP is very classic. Get a physical therapist evaluation, but not every physical therapist. And this is the difficult part, because your doctor need to help you to identify the physical therapist. So if you don't have a doctor or a neurologist who know the team around you, then you need to look for a therapist with this type of a specialist. Okay, remember that in even in physical therapy there is a lot of specialties. So you have a geriatric PT, and you have also physical therapists specialized in neurology, which is like a 1 year extra, and you need to take a certificate and all these things. So try to get or a geriatric PT or a PT specialized in neurology. So the best thing to do is just to ask your provider if they know a good therapist with experience in patients with Parkinsonism. Remember, not every therapist is the same. The same thing that if you have a team, if you are a track and field runner, your coach is very important. If you have a football player, your coach is extremely important. So the same thing applies in medicine. Sometimes I try this medication, amantadine. Amantadine. We don't have good evidence for that. And there are many reasons for that, but anecdotally, so I have seen patients with some improvement, and then when I stop the medication to see if it really is helping or not, actually is helping. I'm talking about amantadine. So you always start amantadine with a low dose, a 100 milligrams in the morning. Why in the morning? Because if you take it too late, it might cause insomnia. Actually, amantadine is used to treat fatigue in patients with multiple MS. So in Parkinson, we use it frequently because it has some anti-dyskinetic properties. Here I'm using amantadine because my help with the dystonia, abnormal posturing, and also the walking based on very small studies and anecdotally. So remember the doses very low, 100 in the morning, and then after 1 week you can increase to 100 in the morning and 100 at 12 at noon. Or sometimes people use 200 in the morning, so hitting the system hard during the beginning of the day, and then 100 at 12 or 1 p.m. Some people use 100 milligrams 3 times a day as well. Now, people tolerate amantadine pretty well usually. However, I see this frequently when you push the doses, at least when you go to 300 or more, you see this skin discoloration that you see in this patient, right? Not a big deal, but doesn't look good. It's not a big deal, but doesn't look good. We call that livedo reticularis. It's a weird name, but that's the name, the medical term. Livedo reticularis, nothing to do about it. Then that means that that you are taking amantadine and you are taking probably more than 300 or more. So I don't see these livedo reticularis in a patient taking 100. Now, you have to adjust amantadine based on renal function, okay? Because amantadine is eliminated by the kidneys. Now, dystonia. Dystonia is another motor symptoms very commonly seen in patients with PSP, including the face. So this is why many patients, they have excessive contraction of this muscle around your eyes, orbicularis oculi, this muscle here. So they can even they cannot even open the eyes, and there is something that we call apraxia of eyelid opening. So they close, you ask them to close their eyes and you tell them open your eye, they cannot do it. And sometimes they have to touch and open the eyes by themselves in order to open the eyes. So this is a very bad thing because imagine that you have balance issues, and in addition to that, you cannot open your eyes. So how do you treat that? You inject Botox. Very easy to do it. Very easy and tend to be effective. Now, then in the apraxia of eyelid opening, you need to inject in this area here, the pretarsal, lateral pretarsal. Otherwise, it's not going to do anything. So you need to inject here. So doctors specialized on that are the movement disorder neurologists. They are training to correctly inject the correct muscle, right? That's the dystonia, abnormal posturing. Then, and this is the type of toxin that we use, a Botox, Xeomin, and Dysport. I tend to use a Botox or Xeomin. I don't use a Dysport just to avoid confusion to the staff. Now, let's continue with the non-motor symptoms, which many times are worse than the motor symptoms. The same thing with Parkinson's disease. Non-motor symptoms are probably worse. So the first one to discuss is drooling. So remember, you don't need to treat every single symptoms in Parkinsonism. It's only if the symptoms is affecting your function. Even your social function, like drooling. Some people don't care. Some people just use a napkin, and that might be enough. But some people really care about that, and you need to treat. How do you treat? So I don't waste my time with pills, okay? Especially those pills might affect cognition and many other GI issues, causing constipation, more bladder issues. So you don't want to deal with that, especially if you are going to be susceptible to medications by mouth, right? So if you have these issues and you drooling and you want to treat, you want to get treatment, don't waste your time with pills. Just go directly to MyoBlock. MyoBlock would be better. And actually, let me tell you something. I had to switch patient from MyoBlock to Xeomin recently because we could not get MyoBlock. Not a good idea. When I inject Xeomin, probably because the conversion obviously is not the same, they didn't like it. So we had to put them back on MyoBlock. So MyoBlock is always the first choice when we are dealing with drooling. Okay, MyoBlock. Now, depression and anxiety, or both. Many patients, they have both. So depression is a very common thing, and either because it's connected somehow with the disease, with the pathophysiology of the disease, or obviously I would feel really depressed. There's a reason to feel depressed if somebody tell me that I have PSP. This is something that I would say more than 99% of the patient would feel depressed if somebody tell you that you have colon cancer stage 4, right? So the same thing happens if somebody tell you that you have PSP, because this is not Parkinson's disease. This is different. So I will tell you what are my favorite medication for PSP, and this is because of side effect profiles and effectiveness. So sertraline, people tolerate sertraline very well, very well. It might have some GI issues in some patients like diarrhea, but typically people tolerate Zoloft. Start with a low dose. It doesn't matter what the pharmacists tell you that they start with 50. No. 25, very low dose, and go up progressively. Every week you increase by 25. And if you are treating anxiety, you need higher doses, at least 100. Otherwise, it's not going to touch you. So depression tend to improve with a lower dose. Anxiety require higher doses. Why that happened? I don't have any idea. I don't know why. Another choice, which is pretty good too, and tend to work faster, apparently, is escitalopram or Lexapro. So the therapeutic dose is 10 milligrams, minimal therapeutic dose. But you always start with 5. So half of the tablet for 1 week, and then go up to 10 if you are able to tolerate. People usually tolerate this medication pretty well. If you have pain, if you have a musculoskeletal pain, try Cymbalta or duloxetine, right? Duloxetine or venlafaxine, which has the same mechanism of action, similar. That's Cymbalta. Both of them help with the pain because they work in not only serotonin, also in norepinephrine, which is related with the pain. Now, if you have insomnia and you are losing weight, I prefer to use mirtazapine. Okay, mirtazapine start with a low dose of 7.5 milligrams, which means we don't have 7.5 milligrams, we have 15, so you cut that. I believe we don't have 7.5. Just double check with that. But anyway, 7.5 milligrams at night, 1 hour before bedtime, and go up progressively by 7.5. Okay. Next, insomnia. Big deal. This is a big deal. Insomnia is a big deal in PSP. All the patients that I see with PSP, they have some insomnia going on. That's a big deal. For some reason, I don't understand, even worse than people with Parkinson. So sleep hygiene, paramount. So it doesn't matter what pills do you take, what do you do. If you don't go to bed at the same time and wake up at the same time and avoid naps during the day, this is not going to work. This is not going to work. That's the first thing to do. And with and without Parkinsonism, it doesn't matter. If you have insomnia, you need to have a structure. Otherwise, it's not going to work. Mirtazapine, as I mentioned before, good choice to start, 7.5 milligrams. And when I say you can actually combine with trazodone. Start with 25. Some people start with 50. That's fine. I always start low. Okay. Why? Because the most important thing during the beginning when you start medication is I want you to tolerate the medication. Then we talk about the benefits. You tolerate the medication so you can go up. Otherwise, that will create some issues that every time that you try this type of medication, you will feel like you are going to have a side effect, and if you look for side effect, you will have a side effect. So start always low. Melatonin Another choice actually should be the first choice because it's in terms of safety profile by far better than any other medications. And melatonin is actually over the counter. You don't need a prescription. You can get that in any pharmacy. Doses for melatonin, don't waste your time with one. It's at least 3 to 5. At least 3 to 5 and 1 hour. I prefer 2 hours before bedtime. And remember, if you go to bed at 10, it's at 10, not one day at 10 and the next day at 12. That doesn't work like that. It's at 10 every single day at 10, and you take your melatonin at 8 p.m. Okay, you put the clock, do something to you for you to remember that you had to take the pill at 2 hours before uh, uh, bedtime. And then you can increase even to 10 or even 12 or 15 milligrams. More than 15, I rarely go more than 15. And monitor for changes in daytime alertness. Okay, because that's one of the side effects that we don't like. Another one that I use is quetiapine or Seroquel. Quetiapine, Seroquel. Remember that I'm giving you the commercial and the generic name, okay? It's just this is difficult in medicine because sometimes you have to learn both names, so it's more and more and more things to learn. So quetiapine is another option, especially if the patient is having severe, and I say severe because if it's mild, you don't need to treat every single symptoms. Irritability, so agitation. If those issues are severe enough and you have insomnia, you can start with Seroquel, quetiapine. How much? Again, low dose, 12.5. So we don't have 12.5 milligram tablet. That doesn't exist. We have 25. So you cut that. You cut that in half. And you don't need to be perfect, like cutting right in. You try, but you don't need to be perfect. Okay. Sometimes it's very difficult. Sometimes you can get 15 milligrams, and the next day you get 10 milligrams or 10 point something. So you don't need to be perfect, but try to cut right in the middle. The other medication that sometimes I try, and it's because we have some evidence, and I can show you here. This is the paper. You can read this paper from published in 1999 that Zolpidem or Ambien, people know Ambien, 5 milligrams at bedtime. Don't go over that. Because you might be looking for side effects, especially worsening of balance and more confusion in some patients that they are susceptible for confusion, and you are giving a medication that might cause confusion, so it will be worse. But sometimes in this type of patient, you need to try things, okay? And because we have data that might probably improve eye movements, okay, based on small studies, you can try because it might help with other things too. Okay, if that doesn't work, you stop. But you can try because that improves the insomnia. And you might use the long acting or the short acting. I tend to use the long acting actually, which is a different milligrams. I think 6 point something. I don't remember exactly the doses, but try the long acting probably would be better, I think. Now, no motor symptoms, continue with that. This is something very common that you see is emotional liability, or what we call pseudobulbar affect, which is those patients that out of the blue, they start crying and they don't feel depressed. They just cry out of the blue. You are talking to them and out of the blue, they start crying, or they might actually laugh. So there's no connection about the emotions and real emotions of how they feel and the crying and the laughing. So sometimes it might be very bad that you require treatment. If again, you don't need to treat every single symptom, but if you need treatment because it's affecting even your social function, then this is you can try always first SSRIs, all right, which is very safe, nortriptyline. We tried 3-cyclic antidepressant, nortriptyline. I will avoid amitriptyline due to the significant cognitive side effect that you might have with a strong anticholinergic effect or of amitriptyline. So I will use the sister, nortriptyline. But also I can use sertraline or escitalopram that might help. If that doesn't help, then you go to this medication, Nudesta, okay, which is specifically approved for this disorder, which you can see that in many neurodegenerative diseases. Also, you see that with other diseases like even stroke. So the most important thing that you need to understand, and actually you need to tell the doctor if you have cardiac arrhythmias, okay? Tell your doctor you have history of cardiac arrhythmia because this medication might prolong the QT interval. And so you don't want to take any risk. So I typically check electrolytes specifically for potassium and magnesium in these patients and liver function test because this medication is metabolized in the liver. That's why it's so important to have these labs before starting this medication. I'm talking about Nudesta. Next, overactive bladder. Very common thing that happens in any patient with Parkinsonism, but even I think more frequent. Actually, not more frequent. You see that a lot too, overactive bladder. So I use Miravegron or Vivegron Gentisa, okay, because those two medications they tend to be safe from the cognition standpoint, different from oxybutynin. So oxybutynin is a no-no for any patient with Parkinsonism, okay, with primary Parkinsonism, including Parkinson's disease, is a no-no. I will avoid those medications, especially in patients with already cognitive issues. If you don't have cognitive issues, then it's okay, right? I think it's okay, but just monitor for cognition. So the best medication to use, again, for overactive bladder are these two so far. Swallowing issues. So the first thing to do is, number one, get educated by techniques to avoid aspiration, okay? For example, the position of your head. So if you are eating and you are lifting the chin up like this, what happens is you are opening your airway, so the food or the liquid will go to the incorrect pipe, and then you will choke, right? So try to keep the chin like this, a little bit flex. And when you eat, you just eat, don't talk. Unfortunately, it's like that because you need to concentrate in what you're doing. So that's the first thing. But just get evaluated by speech therapists. They are expert in swallowing, and they will evaluate. They will teach you some techniques, some exercises to improve the strength of those muscles around the area, right? And if you cannot afford, or you don't, or the insurance doesn't cover, or whatever reason that you cannot get speech therapy, then you go to this website. Actually, this website, they have a lot of information. Is specifically designed for Parkinson's disease, but also other type of Parkinsonism as well. So because applied similarly, right? Now, in severe cases, you need because the case is so severe that you need a peg tooth, which is a feeding tooth. Now, this is controversial, right? I don't know if I will get that if my father get PSP, Richardson syndrome, if I will get a peg tooth. I don't know. It's just a difficult situation, difficult to decide. Yeah. Next, cognitive deficit. And remember, dementia means cognitive dysfunction with sufficient magnitude to affect your daily activity. That's the definition of dementia, right? Dementia causes dementia. There are many. Alzheimer's is the most common one, but PSP is one of them too, right? So, and that's, we are talking about PSP here. So unfortunately, there is no medication that have shown any benefits, clear benefits in dementia for patients with PSP. okay, including Aricept, donepezil. Actually, there's some evidence that donepezil, it might make the motor symptoms even worse in patients with PSP. So sometimes we try because we don't have anything else, but if I don't see any benefit in 2 months, and sometimes it's very difficult to know if it's helping or not, because patients, obviously they cannot tell, and the family, they are not going to be sure. So I typically, I try, and if I don't see any benefit, or if I see worsening of mobility, then I taper down, okay? And I usually try donepezil or Exelon rivastigmine. But again, this is off-label, no evidence to justify that. Now, are you interested in research? And this is important because if you want to get or to help to find the cure for this disease, you should be involved in research, or at least try to be involved in research. So this is the website I would recommend. Number one, this one is the most important one, which is if you want to know what type of clinical trials are available around your area, you go to clinicaltrial.gov. So you go there, you put your area where you live. For example, you live in Tennessee, you put Tennessee, and you will see all the available research in PSP. But this is an excellent website to help you out to find out the trial that are happening around the world, not just US. And then this is a very, very nice website, which is Cure PSP. This is give you information about PSP, more than what I'm telling you here, and also give you information about where to find clinical trials. Okay, very, very important. Just to finalize, I cannot emphasize more palliative care. How important is palliative care from the beginning in patients with PSP? Very important. So I tend to involve palliative care from the beginning when I see a patient that I suspect PSP. They will help you to address the physical, emotional, and social, psychosocial aspect of PSP to improve your quality of life, not just the quality of life of patients with PSP, but also the people around PSP patient, the family, caregivers. If you like this video, don't forget to subscribe to my channel. If you want to have an appointment at GEM Neurology, call this number if you live in the state of Tennessee. See you soon. Thank you for watching.